Hello, this is John Kanellopoulos from our office here in Athens, Greece. Unfortunately, we're not in Amsterdam, where the ESCRS meeting was supposed to be this year, this October 2020. This is our presentation on our signature technique, topography-modified refraction for LASIK, meaning changing the amount and axis of the astigmatism treated in topo-guided LASIK with the X500 excimer laser by Alcon towards the axis and amount of astigmatism suggested by the topographic platform. Very interesting concept. In this investigator-initiated trial, we're comparing 50% TMR to 100% TMR to standard clinical refraction.
Professor Kanellopoulos from Greece, he doesn't need extra introduction. He will talk about topography-modified refraction, partial or total adjustment of treated cylinder mount and axis provided, so it's a long title, please.
Hello, this is John Kanellopoulos. It's my pleasure to share with you the data from this very interesting study we designed to evaluate better our signature TMR, TMR being topography-modified refraction used in topography-guided LASIK in myopic eyes, where the manifest clinical refraction that has been the gold standard till now is changed in regard to the amount and axis of astigmatism based on the suggested topographic data. Now, in this study, that was prospective randomized contralateral eye, and it was sponsored as an investigator-initiated trial by Alcon Laboratories, Greece. It was prospective, as I mentioned, included 296 eyes of 148 consecutive patients. And interestingly enough, each patient had one eye randomized to be treated with TMR. And furthermore, if that eye was randomized to receive TMR, it was randomized for a second time to receive either 50% TMR or 100% TMR. 50% TMR being going halfway between the difference of the amount and axis difference between the manifest and the topographic suggested axis and amount of cylinder. Now, the contralateral eye did go ahead with the standard manifest clinical refraction and had topographic-guided LASIK. On our next slide, to understand the concept of TMR, this is, of course, an extreme patient where you can see that the manifest refraction places the axis of the astigmatism at 135 degrees, steeper axis, flat axis at 45 degrees, half a diopter on the manifest refraction, where it is clear that topographically this is a clearly with the rule astigmatic patient with 1.1 diopters of astigmatism measured by topography. And the reason for this, and I wanted to spend a few seconds, is due to angle kappa. Despite the fact that this astigmatism is perfectly regular, we would say, if there's slight angle kappa, and we see that the y-axis is displaced 280 microns, the x-axis 30 microns, this may make regular astigmatism act as a prism for the patient, and this is what the topography-guided is trying to treat as coma. When we look on the right, the zero set topography-guided fix for this particular eye. So if you are going to treat topography-guided, you have to take into account that that's going to correct that coma, and then manifest refraction may change, may go closer to suggested refraction. So thus, a little more detail here, if we treat topo-guided and we employ our TMR technique, we would indeed treat the full topographic amount of cylinder and axis, and of course adjust the sphere accordingly. So if we increase the amount of astigmatism, we'll reduce the sphere accordingly, and vice versa on this slide in detail account. Now, a little bit more detail. This is two eyes of the same patient. One treated TMR, one treated just topo-guided clinical refraction. Both are 20/20, but we can clearly see that the left eye here has a more topographically neutral result, better maximum visual acuity, and thus we're seeking. So in our study, which we found extremely different, interesting, is that the differences between the 50% TMR and the 100% TMR groups at the 20/20 and the over 20/20 levels were not statistically significant, P being less than, more rather than 0.05 in both comparisons. Now, the differences between the standard and the 50% TMR groups at the 20/20 and the over 20/20 levels were statistically significant. So it was better in visual function accomplished to have TMR. Um, and that difference was statistically significant, although 50% TMR and 100% TMR were not that different between them. And I think nothing illustrates this more than the image on the bottom right here that shows the cumulative percent of eyes and postoperative standard visual acuity. That shows that all eyes did very well, though if we look at the eyes that performed more than 20/20, the TMR eyes ruled here with very small difference between data, and this is the most important graph of our study. Here on the bottom left, the gain of 2 or more lines. Clearly, 100% TMR did the best. 1 out of 3 eyes gained 2 lines or more, almost 30% with 50% TMR. That's not bad, and just 10% still an excellent result with the standard clinical refraction. More detail on the right on additional data on spherical equivalent approach and residual astigmatism, which was of course groups and best in the 100% TMR. So in conclusion, we found that topography, and I think proved that topography-modified refraction that we introduced several years ago is superior to using the manifest clinical data and topography-guided treatments. It was superior in all the data that we studied. Interestingly enough, for us, 50% TMR appears to be almost as good as 100% TMR. For those of us who are a little bit reluctant, 50% is a good area to start with, and it may be sufficient to give the effective improvement that we're seeking. Of course, further studies are needed to confirm these data, and clinicians, even if not adapting, should at least be aware of these important steps. Again, financial disclosures of the Alcon relationship. Thanks.
Thank you, John. I see that you are doing surgery even on a Sunday morning, so
Yes,
well,
yes.
I have one question for you. Did you check actually regarding the outcome if the aberration, the eye order aberration were different between your two groups? Because I think that it's more in terms of quality of vision that you can refine the differences between the two.
That's an excellent question, Beatrice, and so nice to be here with you. Actually, I stayed in the office the whole weekend. That's why I'm still in Greens.
Oh, you live there.
I live here for the ESCRS meeting. This is our life. Excellent question, and we looked carefully at coma and trifoil, and thank you so much for asking this question. Interestingly enough, trifoil had no difference, meaning trifoil is treated very well with topo-guided, regardless of the clinical refraction. Coma is also treated by default because most of the coma lies on the cornea. The difference is in the low aberrations, meaning in the astigmatism. The eyes that were not treated TMR had more astigmatism. And our argument here is you have a 5-year-old boy, very typical in Greece, who has 3 diopters of topographic astigmatism and is seeing 20/20. How can that happen? Accommodation, tilting, working, using that astigmatism as a prism. So if we have a 25-year-old gentleman who has 1.5 diopter of regular astigmatism and an angle cap of 300 microns, he may be refracting only half a diopter of astigmatism on a different axis. If you do a waveform optimized procedure, this error will carry on for the rest of his life. If you do a topo-guided procedure, you're compelled to consider the actual topographic cylinder, taken of course if you confirm it with a Pendicam, with a full tomography, because the posterior cornea surface may be a little bit funny and maybe throwing off the astigmatism. So we argue that this is a chance when you're doing LASIK to optimize the optics of the cornea in regard to the cornea vertex, meaning the area of the cornea the patient is using as his or her visual axis.
We don't have so much time to go any further, but I get that you are planning to use this program for hyperopic treatment, because I mean integrating the kappa angle would make even more sense in the hyperopic treatment, right?
Of course. Their angle kappa is almost universal.
Yeah, absolutely. Thank you very much.
Thank you so much.
I think that, I mean, the last but not the least.
Well, I regret not being able to be with our family all together in Amsterdam and having a fruitful discussion on these really compelling outcomes of our study and applying TMR routine myopic LASIK using the topography platform by Alcon. I want to thank you so much for your attention. We had over 250 attendees in this session and more. I want to thank the moderators and the ESRS for giving us the opportunity and exchanging all these great ideas of science. This is John Kanellopoulos signing out. Thanks so much.